And the topic is low prognosis patients and an introduction to the POSEIDON criteria. This is my disclosure. And I also have a question for you. So, how often POSEIDON patients are seen in your fertility clinic? 10%, 20%, 40%, 65%? What do you think? So we shall see. So 61% of you decided on 40%. And there are some other ideas as well. And the answer, if you listen very carefully, you will hear within the presentation. So, excuse me. So predicting factors in ART treatment, and this was a paper some years ago, a meta-analysis. We can have negative and positive predictive factors. The most important positive predictive factors are the numbers of oocytes that we retrieve and the number and the quality of the embryos that we transfer. Now, concerning the number of the oocytes, there have been several papers looking at fresh live birth rate and cumulative live birth rate. And as you can see, by increasing the number of the oocytes, the live birth rate will increase, but then it will stagnate at around 10 to 15 oocytes. The cumulative live birth rate is increasing even beyond this number of oocytes. But is the number of the oocytes the same concerning the prognosis of the patient in different age group? And the answer is no. As you can see here from this Swiss paper, in different age group with the same number of oocytes, you will have a different prognosis of the patient. And this is especially important with the very low numbers of oocytes. So if you have 4 oocytes or 3 oocytes and you are 30 years old, you will have a different prognosis than if you are 40 years old. And again, some papers looked and it is accepted that female age and the number of the oocyte will predict the probability of the live birth in ART treatment. So there have been many definitions about reaction to stimulation, poor prognosis, low prognosis, like 47 definitions in one of the papers, and some papers even having the same authors use different definitions for the same things in the papers. So we decided that we have to go a different way in order to assess the prognosis of the patients. So not just looking at the numbers of the oocytes, like the Bologna criteria that was established by the ESHRE, but also look at the quality of the oocyte, which more or less is represented by the age of the patient, and try to combine both of them. Also trying to find ways how to manage the different subgroups of these different prognosis patients. So we gathered in 2015 in the island of Ischia, and the resort where we were discussing was called POSEIDON. It's a thermal resort, a very nice place. So we decided to call the group Poseidon because we were there. And it took us about 3 hours to find the acronym for Poseidon scientifically. So it's a patient-oriented strategies encompassing individualized oocyte number. So this is Poseidon. And here you can see the first members of the Poseidon who are discussing over 2 days. And that was the first paper that was delivered in 2016 in Fertility and Sterility. Now, a new more detailed stratification of low responders to ovarian stimulation, moving from poor ovarian response to a low prognosis concept. And one of the members is unfortunately not anymore with us. This is my friend from Germany, Dr. Klaus Bühler, who passed away this April this year, and we miss him very much. He was a very active member of our Poseidon group, and we shall remember him, of course. So the Poseidon classification is not another poor ovarian response criteria. So this is what we want to emphasize. We only try to identify patients with low prognosis and stratify them according to distinct categories. So it's a new way of thinking. And we use, of course, different strategies how to find out this group of patients. So the one is the ovarian reserve. And for ovarian reserve, we are using ovarian markers. And ovarian markers can be either antral follicle count or AMH, and a good marker should predict the pool of follicles and oocytes that we can achieve, but a good marker also should tell us something about the quality of the oocyte and live birth prediction. So AFC and AMH are very good markers to tell us something about the number of the oocytes, and you can use each of them or you can use both of them together. Probably there will be not much difference, and the accuracy is very high. It's 0.82. But does AMH and AFC tell us something about the probability of live birth rate? Well, as you can see here, the line is not very predictive because AMH and AFC is a marker of quantity, not a marker of quality. So what about the quality? We know that in advanced maternal age, the quality of the oocytes, that the number of the oocytes will be reduced, but also the quality is changing. Here, for example, just looking at mitochondria viability in 2 different age groups, less than 35 and over 35, and you see a huge difference in the mitochondria viability. Euploidity rate of the nucleus. This is data from my center because in Germany we are not allowed to do PGTA on the embryo, so we do it on the polar body. So we have information on the oocyte. And as you can see, the probability to have a euploid oocyte at the age of up to 35 is around 50%, 50-55%. But after that, there is a continuous decline. So at the age of 40, 41, it's only about 15% of the oocytes which are genetically normal. And year by year, the probability to have a euploid blastocyst will dramatically increase, as you can see here. This is the changes from 1 year to the other, a percentage of decrease in the probability to find a euploid blastocyst. And when we look at the very famous paper by Barishata some years ago, you can see, again, if you look now at the euploidity of blastocysts, you see exactly the same result that we saw on the oocytes. The probability at the age over 40 is like 15% to have a euploid blastocyst. And the rate is independent from the number. Of course, if you have a higher number, the probability to find at least one blastocyst will be higher. But once we transfer a euploid blastocyst, and here you can see data from my center. This is on polar body genetic testing, and this is data from Filippo Valdi's center in Rome. If you transfer independent from the age a euploid blastocyst, you will have the same implantation rate and the same live birth rate. So it is important to try to find a euploid blastocyst in order to have a good result independent by the age. There are also some other factors that will affect, and you will hear more about it from Carlo Alvigi later on. I'm just touching now a few points. And as you know, repetition is the mother of knowledge. So a few things you will hear a few times today, and this is helpful. So the sensitivity to the FSH, the response of the follicle, the growth of the follicle, and the maturation of the oocyte is important. And we can have different sensitivity to a gonadotropin stimulation. And the ratio between the preovulatory follicle to the starting antral follicle number is called FORT, which is follicle output rate. And POSEIDON also introduced a new marker that Carlo Alvigi also informed you later on that, which is FOI, which is the follicle oocyte index. And here the cutoff point will be 50%. So if you end up with more than 50% of oocytes from the started follicle, it is a good situation. And if you are less than that, there is a problem. And of course, this can also involve some different pathogenesis, which helps us to find out the reason why we ended up with less oocytes that we would actually wanted to have. The most common reason for different sensitivity is the FSH receptor polymorphisms. And as you can see, this situation can be in a homozygote. You will find here in Europe, at least in about around 20% of the patients having the homozygote FSH serine 680 homozygote, and about half of the population will be heterozygote. So it is quite important to look at these aspects. But also polymorphisms of the gonadotropins, especially the LH molecule, which is called the beta variant LH, is one of the main reasons that we shall have suboptimal reaction of the follicles to the stimulation. And we have this kind of beta variant LH in about 15% of the population here in Europe. So 1 in 6 patients will have this problem. And when we look in the subgroups of so-called hyporesponder patient who doesn't react correctly to the stimulation, we shall find about 60% of the patients will have the FSH 680 serine homozygote, and about 23% will be heterozygote, so almost around more than 80% will have a problem. So it is a factor that one should think about it when we discuss about stimulation dosing gonadotropins that we want to use. And also there are some LH receptors which are known to influence the sensitivity of the follicles to the stimulation that we are using. So at the POSEIDON criteria, we use different aspects. We use the age of the patient, we use ovarian biomarkers, and we use information from previous cycles to see how patients reacted to a given stimulation protocol concerning FORT or FOI that I mentioned before. And that's why we divided the patient actually in 4 different groups, considering the age and the ovarian reserve. So we have patients who are good ovarian reserves and patients who have poor ovarian reserve. And then within them, we divided them into older and younger patients. So that's how we came up with 4 significant groups. And within group 1 and group 2, we have also a subdivision of patients. These are patients who have good ovarian reserve, but unexpectedly have either a suboptimal or a very low number of oocytes at the end of a adequate stimulation. Group 3 and group 4 are patients young or old, which are expected to have a low number of oocytes, but because of the age, they have now a different prognosis and a different management how to go on with the stimulation to increase the prognosis of this patient. And here is another way how, in a pictogram, to look and to understand this situation. Now, we decided at the age of 35 because several studies and also this year euploidy probability evaluation by Sandro Esteves showed that the cut-off point of the euploidity of the oocytes and the embryos is around the age of 35. And so that's why we decided of a cut-off point between the group of the age of 35. So group 1 of patients are patients with good ovarian reserve, but a low prognosis because they have a different sensitivity to FSH. So these are hyporesponders patients. Group 2 are also hyporesponder patients, but in advanced maternal age. And here it is important to think about the quality, the genetical quality of the oocytes, because here they play a role. And this has a role that we see later on in the management of this patient. Groups 3 and 4 are what we call actually the Bologna criteria patient, because they are expected to have a low number of the oocytes. And again, because of the age, they will have different prognosis and a different management in order to achieve an adequate treatment. We have studied all these criteria and tried to evaluate them. So in a big paper looking in 3 different countries in 3 different places, and Hakan Yarali was one of the groups that was looking at the population. You can see it was a little bit different from country to country, but basically about 43% of the patients that you see in your center might belong to the POSEIDON subgroup. And you can see that there are different group 1 and group 2 are the most common ones, and the groups 3 and 4 a little bit less. The smallest group is usually group 3. It was also validated that antral follicle count and anti-mullerian hormone are good predictors to classify patients in the subgroups. And when we looked at the cumulative live birth rate, we could see and identify that all the POSEIDON subgroup patients have a lower prognosis compared to non-POSEIDON patients. And also within the subgroups, we have a different prognosis concerning the cumulative live birth rate. And group 1 and group 3, which are the younger patients, are of course having the better prognosis than group 2 and 4. The lowest prognosis is of course with group 4 with the expected low number and advanced maternal age. So all those once confirmed in these papers and the evaluation of the. So the POSEIDON working group also decided about a new measurement of a successful treatment. So what is a successful treatment? So a successful treatment will be the ability to retrieve the number of oocytes which are necessary to obtain in order to achieve at least 1 euploid embryo for transfer in a patient. And we also developed, especially Sandro Esteves a calculator, ART calculator, where you can enter all kind of information, and either from your center or from the literature, to find out in a given patient couple what will be the number of oocytes that will need to be achieved in order to have this one euploid blastocyst. And if you retrieve less than that, you can enter also the information, what will be the probability within this number that you achieved to find at least one euploid embryo. This calculator is on the POSEIDON website, so you are very much welcome to go to the website and use this calculator, which can help you consulting your patients in your center. And this was also validated in the paper. Because of the time, I will not go now too much into the details. So how do we work with the POSEIDON subgroups? Well, we first look at the ovarian marker of a patient when we see the patient the first time, and we see if it's abnormal or adequate. So if it's abnormal, we look at the age of the patient and we decide if they belong to group 3 or group 4. If it is normal and we have information about previous treatment, and we see that it was an not adequate reaction, then again we decide if it's a non-POSEIDON patient. If she was adequate, then it's a non-POSEIDON patient. But it was not adequate, then again by the age we decide if it belongs to group 1 or group 2. Of course, you can do also pharmacogenetics that Carlo will talk about it, and without information about previous cycle, you can decide if the patient will belong to group 1 or 2 if she has a polymorphism of the FSH receptor. And then the second step is, after stratification, is to estimate using the calculator what will be the number of the oocyte in this given couple in order to achieve the blastocyst. And then you decide on which management you want to do, and you discuss this with the patient in order to achieve the goal. So POSEIDON had introduced, as you can see, several things: the criteria, the intermediate markers, the description of the Foy oocyte index. And this is helping now, of course, the clinician in order to work daily with the patients and decide on the management. It helps the patient to understand what are the problems and what will be the management. And it also helps researchers because we have more homogeneous subgroups now in order to do research and to find out ways of treatments. And so here you can see the brief history of the POSEIDON subgroup over the years up to now. And we had in 2022 also the first POSEIDON World Conference in Lisbon in Portugal. So thank you very much. And within the next presentation, we shall highlight to you now also the management of some of these subgroups. Thank you.
Indeed.